Hello, good morning, good afternoon, and good evening. I'm Dr. Rose Clarke, Vice Chancellor, Clarke International University in Uganda. I'm delighted to be the moderator for today's conversation. Hindsight is 2020, investing in the health of health and care workers. Before we start the conversation, before I introduce our panelists, here are a few undeniable truths. The power and impact of the health and care workforce across the globe is immeasurable. However, in the context of COVID-19, delivering quality care has placed millions of health workers at risk, quite often at the detriment of their own physical and mental well-being. Recent data show that a health worker dies every 30 minutes due to COVID-19. Therefore, critical investments in the health and well-being of health and care workers are not only urgently needed, but they need to be sustained. The WHO's campaign, "Applause is not enough," is a call to action for all of us. We all have a moral obligation to care for the health and care workers who continue to make personal sacrifices on the front line. But if applause is not enough, what is enough? And that is the question our panelists today are going to help us answer. I am pleased to introduce to you two panels this afternoon of practitioners who will, in the next hour, explore opportunities and ways in which we can all respond to this call to action. Our first panel will explore how we can protect health worker rights and responsibilities, including supporting the distinct needs of women in the workplace. And they will also explore specific resources governments and global leaders must invest in to support the health and care workers across the globe. Please join me in welcoming our first panel, Annette Kanyunyuzi, President of the National Midwives Association in Kampala, Uganda. Margaret Odera, Community Health Worker, Mentor Mother, Mathare North Health Center in Kenya. And Mike Kalipayan, Head Nurse, Eastern Visayas Regional Medical Center in the Philippines. So I'll start right here at home and jump in with Annette Kanyunyuzi. How has the pandemic affected the way you work, Annette, and your ability to provide care? And what are some of the ongoing challenges you are encountering? Annette?
Thank you very much, Dr. Rose. I am Annette Kanyuze and very privileged to be on this panel. And I want to thank the organizers. COVID-19 pandemic has been a big challenge as far as service delivery is concerned. We need to first appreciate what requires quality service delivery. First of all, we need the staffing. And when we look at our staffing levels, we find that in terms of quantity, we still have limited staffing. I'll refer specifically to the numbers in midwifery practice because that is where I work. We find that the number of midwives is far less what is recommended by the World Health Organization. And when it came to the COVID pandemic, this was even worse because most staff were unable to reach the facilities because of lockdown, because transport had been affected, and that brought down the numbers. We are looking also at the workload itself. That means that more patients had to be seen by a few number of staff. And that is a big challenge because it affects the quality of care. It reduces on the amount of time you have to spend with a patient if you're to give quality care and if you're to serve the needs of every patient or client who is coming in for care. So staffing was a big challenge. Up to now, staffing remains a big challenge. The staffing norms in our country and globally are yet to be addressed. When you look at the recommended coverage by WHO, for instance, it is recommended that 2 midwives should care for at least 1,000 mothers. But currently in Uganda, we find that 1 midwives looks after to 2,000 or more. So with COVID, this was even worse. Staffing issues aside, we have issues as far as the working environment itself. When you look at our infrastructure, it is still constrained. Most of the infrastructure were put up in several years, in centuries, at least a century from now. And it's quite a challenge, infrastructure, And when you look at COVID, this implied that the staff had to stay longer in this, environment. They had to stay longer in the environment, yet the environment was not structured in that way that staff can stay overnight, staff can, pay attention to their sanitation needs, staff can be able to rest adequately. We saw structures being changed from units or wards to house staff. And definitely if these structures were not meant to be for housing, then that means there was a problem with quality. So staffing, housing and infrastructure has been a challenge, it still is a challenge, because we know like curfew is still in place in our country, and yet the staff are not housed. So it requires the staff to travel a long distance, and sometimes they leave the workplaces beyond the acceptable time, and by the time they reach home, some of them are caught up with a curfew. And it takes a toll on these staff to keep explaining themselves to the security why they are late. And when you don't find a very reasonable security personnel, it is really a big challenge. We saw in the media when COVID was there how some of the staff actually, the health workers, fell victims of these restrictions.
I believe we've lost Annette. We are not able to hear.
I'm still on, Dr. Rose. I think it was network interruption. Then we look at the supplies. When we talk about an enabling environment, we want to look at the supplies. And I'll start with the personal protective equipment for the health workers. COVID came in and it was quite abrupt. It was a challenge on our already struggling supply availability. So you find that the staff had challenges with accessing personal protective equipment. And that in some instances brought in reluctance to serve. But for those staff who were able to persevere, that is where maybe we could say there was a breach in protection, a gap in protection, and some of the staff ended up getting the infections.
Yes,
So
and probably indeed, Annette, where we need the investment indeed. And I'm sorry to cut you there, but I want to move on a little bit to Margaret so that she can elaborate a little bit more from her perspective, therefore, what are the key priority areas that the government and global leaders must invest in to ensure health workers are protected and supported? Margaret, Annette raises all of these issues of lack of PPE and protection, lack of housing, health workers at risk. What are the key priority areas, therefore, that we must invest in, like now, Miss Margaret?
Okay, thank you very much for this opportunity. So, the first priority I would like the government to intervene is a constant supply of drugs. As a HIV positive mother myself, I have clients who are right now, we are in fear because there is an acute shortage of ARVs in Kenya, in the whole country. So I would like this issue to be addressed. Right now, I got a COVID vaccine in February. I have to get another jab in May, and I have not gotten that jab. So there is an acute, there is no flow of a constant supply of drugs. And this affects me as a health worker, and it also affects the clients that we are serving in our community. Another issue that I would like to be addressed is the issue of the community health workers. As a community health worker in Kenya, we are working as volunteers. And because we work as a bridge between the community and the facility, if we are not economically empowered, I don't think that there'll be an effective flow as far as medical is concerned. Yeah, another issue is the lack of PPEs, as my colleagues have said. As community health workers, as a mother living with HIV, and I know that health workers have different conditions themselves. So we need a constant supply of protection, protective gears such as masks, enough head-to-toe protective gear is very important for us. Another issue is a psychological issue. As a health worker who has kids, as a mother with kids, and on the behalf of other health workers who are nurses and doctors, COVID-19 has brought a lot of stress in the health sector. Health workers are so much stressed because of this pandemic. Some of us have been overwhelmed, in March, in February and March, the nurses had not been paid for around 4 months, and this resulted into a constant, strikes. The nurses and the doctors since November up to April, we were just on strike, and this drastically affected the health sector, especially the mothers who are giving birth. Many mothers gave birth on the way. Some of them died. Some of the babies died. So it really affected, and it's because of this COVID pandemic. I think the government was overwhelmed. So constant supply of drugs, economic empowerment, and then I would suggest an equity to all health workers, from the doctors, nurses, community health workers, to coming down to cleaners and porters. These are very, very important people who are staffs of IPC, infection prevention. If these staffs who are down, the cleaners are not considered to be, important, we still are going to have a problem in the health sector. Because if a cleaner is not trained properly, we are still going to have a problem. So constant training also. We need constant training for the cleaners, cooks, and community health workers, so that we know the updates that are supposed to be there. For some of us community health workers, we don't know the constant updates because we are not taken to constant trainings. So if these updates are brought down to a community health worker, to a cleaner, so that she may have the knowledge of IPC, what to do, what not to do for a patient, I think that is very important for us. Thank you very much.
Thank you so much, Margaret. And you raised such an important issue. Sometimes we forget that every worker in the link is important. Every block important. And if we are missing that one block, the whole house goes down. And therefore, investment needs to cover every healthcare worker. Thank you for your testimony. Michael, now we move on to you. Most of the time, health workers are not able to advocate for themselves. They are always busy working. They are on the front line. They don't have time. They don't have a voice. How do we equip health and care workers to advocate for themselves so that we can start to see needed changes within the health system, given all these issues that both Margaret are raising? Mike.
Thank you for having me to be one of the panelists. Okay. Um, in this pandemic, we have heard about problems in PPE, infrastructures, vaccine, just compensation, and a while ago, you mentioned about training for all health workers, regardless of a position. For me, I am advocating for mental health problems, or I'm advocating for mental health for workers. Let me share a quotation that would best fit that that would be a fit answer that question. It says, "The advice I give to somebody that is silently struggling is you don't have to live that way. You don't have to struggle in silence. You can be unsilent. You can live well with a mental health condition as long as you open up to somebody about it, because it's really important you share your experience with people so that you can get the help that you need." What I am trying to insinuate here is that nurses, if we want to advocate for ourselves, we need to be heard. Gone are the days that we are meek and silent. It's time for us to speak. What we can do is actually number one, we need to encourage your local politician, heads of your respective hospital agency to prioritize mental health. Next is participate in research about mental health. Next is organized group to gain funding or financing. Number four is have a definite policies and programs in workplace that support mental health. Next is let us organize an information dissemination about mental health. Next is let us encourage an environment where everybody can freely talk about mental health. And lastly, tell yourself and everybody that sometimes it is okay not to be okay. And that will be all.
Thank you so much. You bring that issue up. In my remarks, I said that, quite often nurses and doctors and other healthcare workers continue to commit and take risks, often to the detriment of their own physical and mental health well-being. In 1 minute, I'm going to go back to Annette. What are some of the actions that need to be taken to take care of healthcare workers as well? Healthcare workers are often sick, and I think we forget that they do need care. So Annette, what should the government do to support what Michael is talking about, both the physical and mental well-being of care workers?
Thank you very much, Dr. Rose. One of the things I think we need to do is go back and look at the existing policies, guidelines, and re-examine them. I looked at some of the available policies, and I found that these policies that are actually in place are good enough to take care of the health workers. For instance, in Uganda, we have the Occupational Safety Act 9, section 47 to 57. But the challenge there is implementation and enacting of these policies. So we need to see government prioritizing the health needs of these healthcare workers. We need to see budget allocations that really address the needs and are able to have the needs of the health workers taken care of. So apart from policy, we need to see the involvement of the leaders, of the nurses and midwives, because they know best what these requirements, what the needs are. So if the leaders of the nurses and midwives are not involved at the decision-making table, then that's why we find that these policies remain on table, remain in the book. We also need to empower our nurses and midwives at every level, that they should be able to stand, be aware of their rights, and be able to demand to be listened to, demand to ensure that their needs are put into the budgets right at facility level. Yes,
Thank
Rose,
you. Thank you very much.
that is what is missing.
Brilliant points, and I hope that all the policymakers and leaders who are on the call are able to take these into considerations. Margaret, you are at the grassroots, you are in the community, you are a sick patient as well as a provider. Do you have some specific examples of how we can close that gap of implementation, where we are simply not just talking about things, but we are actually implementing things? What has happened in Kenya that you can tell us? 1 minute. Margaret is not on the call. I'll move on to Mike. Mike, are you able to answer that question? What is it that they are doing in the Philippines to translate policy to action so that we are simply not locked in a world of rhetoric? You know, what are some of the actions that are taking place to close that implementation gap? Mike, you are muted. Can you unmute yourself, please?
Okay, sorry. Um, the Philippines has an estimated 110 million population as of speaking, an estimated of 6 nurses per 10,000 populations for our province alone. With this, we are facing a shortage of nurses who are working in a hospital setting, handling COVID patients, and the number of COVID patients is increasing, and the shortage of nurses still persists. And this results for nurses to be overworked physically and mentally stressed and anxious. And this note, more nurses quit and opted to work abroad. And that is one of the problems here in the Philippines. Another challenge is we face is the modification of care on our patient. We can never redefine nursing without patient care in the equation. Our true definition is multifaceted, but this pandemic redefines our role and poses a great limitation, as I have seen a lot of death in my clinical duty. But COVID death is somewhat out of ordinary. It breaks my heart to see those senseless and heartbreaking deaths due to COVID-19, and their family is not beside with them to say their goodbye. And this role is your role in that situation is altered, and you cannot do anything because of many restrictions. So I am encouraging that our government should address this problem. I strongly suggest that our government must provide a psychological and social support intervention plan for nurses. This is a crucial issue we must face and address so that nurses can cope better during this COVID-19 pandemic. And we need also to build our neural pathways for self-awareness, self-regulation through practices like mindfulness, because if it is left unresolved, this can have a long-term consequences. That will be all.
Yes, thank you very much, Mike. And I suppose we need to remember, those of us who are educators, that first, before we can look after anybody, before we can look after the world, before we can look after patients, we really need to consider looking after ourselves. And that needs to be prioritized in organizational policies. Margaret, you will have your last word before we move on to our next panel. And as I mentioned, you are at the grassroots. So how are we harnessing voice? How do we ensure that what is happening at the community level, those policy makers and the government are aware, and we are able to inspire action all the way from the community to the district to the country level? Ms. Margaret.
Number one, let's emphasize so much on the training of a community health worker who stands as a bridge between a community and the facility. And number two is economic empowerment. As a mother, as a HIV positive person, would like to have economic empowerment, and that will be great. That will help me psychologically, because if I don't have money, I will still have stress. If I wonder where my children are going to eat, I'll still have stress. So, and also to have to have time for ourselves, to just set aside time for nurses, doctors, clinical officers, to just sit down and everybody just talk about ourselves, just speak about ourselves, have that rapport between each other. I think that will be helpful for our country. Thank you so much.
Thank you very much. And I want to thank Annette, Margaret, and Mike for their insightful deliberations. And I would like now to move on to our second panel, who are going to explore what it takes to get health worker policy recommendations acted on by policymakers and governments. We have already heard from our first panel, not only do we need economic empowerment, we need to look after the mental and physical well-being of healthcare workers. We have issues with policy to action. There are gaps there. It's not good enough for us to have good policies that we are not able to translate and that we are not able to enforce, or where we are not able to put some money. So I would like to introduce now our second panel. Amanda Banda, Global Health Advocate, WEMOS, and co-chair of Health Workers for All Coalition. Dr. Carolina Hello-Clore, past president of the Honduran Society of Anesthesia, director of programs of the World Federation of Societies of Anesthesiologists, WFSA, and chair of the Gender Balance Ad Hoc Committee of the same organization. Dr. Vanessa Carey, co-founder and CEO of SEED Global Health, and also a critical care physician. Dr. Carolina, let us start with you. People often think of the health system in terms of infrastructure, that is beds, equipment, technology, and they prioritize investments in these resources. How do we compel governments and leaders to center human resources for health and guide investments in that direction? Dr. Carolina.
Well, thank you very much for this opportunity of participation in this panel. If I start from the premise that healthcare safety relies on those three pillars, well-trained human resources, second, equipment and infrastructure, and the third, the pillar, availability of safe medicines. From the three, the one that cannot be missing, therefore, core of a good health system is well-trained, healthy, and well-care healthcare workers. Without this element, all others may be of premium class, but you would never obtain a quality and a sustainable safety healthcare. Then bringing the leading authorities aware that healthcare workers are key in the provision of health services, and that therefore investing in that human potential becomes a priority. This process of awareness involves not only showing the scientific evidence of this starting point with national surveys and local or international studies, but also conversation, dialogues, workshops, training, mind open to change, but with all the parties, not just thinking that just the government or just the academia or just different medical societies, all the parties together. Thank you.
Thank you so much. Dr. Carey, can we build on that? How do we contextualize the issues that health workers face in a way, therefore, that inspires action. That seems to be the thread for our conversation today. How do we inspire action? So how do we contextualize these issues? Can you build on what Dr. Carolina has been talking about? Dr. Vanessa.
Thank you very much for having me today, and I'm very honored to be on this panel with all of you. I think that the work you've been doing is extraordinary and critically important, because as we look at COVID and what is happening in the world today, it is incredibly poignant, you know, the role of the healthcare worker and how important they are to be on the front lines of our COVID response, but also of protecting essential services. We have learned throughout history. So it's about embracing history. It is about waking up to this moment and understanding the power of the human touch in healthcare. Healthcare is a human-centered intervention. And we have learned throughout history that by not having enough healthcare workers, that when we are facing a pandemic or an outbreak, we actually see more death and destruction and loss and morbidity from the loss of essential services that ends up happening for decades after a pandemic than we almost see from the loss of life in the pandemic itself. Dr. Tedros said today that we have lost over 115,000 healthcare workers. That is time and investment that is put into building that healthcare worker, the training, the cultivation of what that individual can do, that is lost in a moment through disease, through a failure to protect them, through a failure to give them the tools that they need. And I think that if we just take the moment to look at all the evidence that we have seen over time, we will remember the importance of a healthcare worker to use technology in the right way to provide better care, to be able to use the medicines and to walk the halls of the clinics that we built and to be able to be on that response. At Seed Global Health, we've seen that firsthand. In Zambia, where we've been working in family medicine in one of the largest hospitals in Lusaka, when patients started to come in with respiratory symptoms that were being deemed as potentially congestive heart failure, it was humans who used ultrasound to diagnose in real time what was viral pneumonia, likely COVID, and it was able to transform and change care. So what we have to realize somehow in this moment, and I've been looking at Twitter and social media throughout the World Health Assembly, everybody is applauding healthcare workers and acknowledging them and thanking them. I am a healthcare worker. I have spent a year watching people die of COVID. I do not want people thanking me. I want people investing in my colleagues around the world, giving them the respect, the tools, the investment, the PPE, the remuneration, the nurturing and protective context to do their job with dignity and to care for the patients that they so deeply want to. But it's a time for action, not just words. And I worry that we are going to stay in words and not actually start to make those needed investments. But I can tell you it will cost us a lot more if we don't make the investments today that were frankly needed to be made over the last 20 years. Thank you.
Thank you so much, Vanessa. You know, when I was thinking about the conversation today, and I read that every 30 minutes, a healthcare worker, a care worker dies around the world. That means that in the time that we are going to be having this conversation, which is 60 minutes, 2 healthcare workers would have lost their lives. This is not really a time for talking, you're right. It is a time for action. And I wonder, therefore, what the challenge really is, because data are available. Data do not lie. So, Amanda, what is it going to take to get health work policy recommendations acted on by the governments? Why are they not listening? The data are written on the wall. And like Vanessa said, we need to keep healthcare workers alive and we need to stop talking. So can you clarify for our audience, what is it going to take to make these recommendations become not just recommendations, but items that are acted on by governments, by all health leaders across the world? Amanda.
Thank you so much, Dr. Rose, for having me on this panel. So I think that maybe I will speak to 5 points in terms of what it takes to translate these policy recommendations to be acted on by governments. And I will start with the data one because it was also like at the top of my mind. So yes, some data is there, but it's not always there. And it's also not always publicly available and accessible, especially by civil society organizations who are could be able to push, governments and hold them accountable. So in a few countries, you will find the most updated, for example, HRH policies and even costing and investment plans. But that's just a few countries. In a lot of countries, you'll find that information exists, but it's outdated. And most governments will not be able to tell you exactly where their healthcare workers are. And a lot of donors, there is a lot of effort now, of course, with multiple donors, the Global Fund, PEPFAR, and others really trying to track where they are placing their healthcare workers. But if you just walked into any HRH health workforce department in any government office to ask, I want you to give me a breakdown of where are your healthcare workers, and how much does it cost, and how much is what donor investing, you will not find that information. And so there's data on how many healthcare workers are dying, but also attrition, how many healthcare workers are migrating and moving across countries. All this data is not readily available and updated. I think we should acknowledge that some governments are doing a good job in this. And also there's a lot of technical support and assistance by a lot of partners that are also investing a lot of resources to do this. But I think that is one thing that if strongly invested in, I think it could bring a lot of changes. And even myself as an advocate, I've been struggling to find global data, like what is the nature and level of investments in human resources for health at the moment? Because if I'm going to go to any particular donor, especially now in the COVID response, we're talking about the health workforce has been left behind. I'm not able to find any of that data. And so often then donors and governments have the misconception that, well, we have enough healthcare workers or not. That's an argument. Or, just because the data and information is not readily available in terms of how much investments are there and how many people we really actually have and have lost, it becomes very difficult. So that's one point that I think is something that has a large bearing and impact in terms of translating policies into actions by governments. And the second one I think is, I have seen, maybe I can just give an example. When I started working in HRH, one of the first things that I worked on was in Malawi. It was an emergency human resource for health plan. And this was a group of donors putting together, I think, $95 million to invest over, must have been a period of 6 years in HRH. So you have the coordination of donors led by the government, making a plan that wasn't just, we are going to pay salaries, but I think it had like 5 layers, if I'm not mistaken. There was, okay, we're gonna top up salaries for healthcare workers. We're gonna build capacity of training institutions to train healthcare workers. We are going to, put a lot of resources in a number of things that really was well thought through. I mean, it included things like technical assistance and volunteers as well to fill in the gaps while they were beefing up the system. So that coordination, harmonization of donors, I think is very essential with the government in leadership to really ensure that where some governments have great HRH policies, they are unable to translate them into action because there is missing resources. And the third point that I want to mention quickly is also coordinated civil society advocacy. I think we need to invest in building capacity towards civil society to talk about human resources for health. I think this is something that is missing. You see in a lot of spaces, HIV, civil society have built capacity in a lot of programs, SRHR, and a number of programs. I think there's capacity being built and investments going into civil society advocacy, but HRH is really one area where nobody really thinks of how do we invest in enabling civil society to do advocacy, because civil society can and do bring results. I think we all agree. And I think that the fourth one, which is unfortunate, I think that I don't know why we have to wait until healthcare workers strike. Until healthcare workers strike. Like, if you really want to get action, like, healthcare workers strike, and that's when you get action. But why does it have to be that we have to wait until healthcare workers strike to get government to respond? Why cannot it not be the other way? We don't want healthcare workers striking, but sometimes it feels like maybe that's the only way they have to get their voices heard. I think Dr. Kerry spoke about COVID, people clapping and everybody saying thank you, but then what, And healthcare workers have been striking across the world. I think we saw an increase in the number of strikes during the COVID because they were asking for PPE, they were asking for so many things that over and over again they were being ignored. And as a last resort, they took to striking. So my last point that I want to mention, I think that I've also seen works, is the strong linkage between the facility level, district level, coordinated platforms of HRH to the national. Also in some instances where I've worked, we have, in most countries, you will have a national level technical working group on human resources for health. And I see what works is where you have a similar structure, either at the provincial or district level, that is closely monitoring the situation in the communities and in the district, and closely also feeding on a regular basis to the national level human resources for health departments and counterparts. Because what we often saw was the national level would be surprised, like, oh, we thought we had 5 nurses in that facility. But when you have a local structure at local governance level monitoring and saying, no, actually 3 of those died, like somebody mentioned the deaths, or one of them moved away, the other one was a lady, she got married, the national level will say, oh, we didn't know, and that's why we have not been posting health workers to that particular district. So this regular capacity building of technical working group structures at local, provincial level, I think is also key. That is then enabled and capacitated to link closely with the national. I think that with these 5 things, maybe I stop here, but I think I've seen that most of them work in terms of getting, policy to action. Thank you.
Brilliant. Thank you so much, Amanda. And you bring up a really interesting point there, where we often see voice coming down at national level, down to the facility level, but harnessing voice from the facility to the provincial, to the district, back to the national. Those links, we haven't really invested in those, and I think that's critically important. So for all 3 of you, I'm going to ask the same question as we wrap this conversation up, and then have some remarks from one of our colleagues who is the director of SEED Global Health in Uganda. So countries, we would like to see some examples of robust investment in health workforce. What approaches have been used? Let me start with Dr. Carolina. What are some of the specific examples that Honduras has undertaken that we can learn from today?
Thank you very much. Well, there are countries from which you learn a lot, countries in which their priority is to invest in full human potential. They work for the common good, listening to all the parties involved, executing processes to this purpose with administrative transparency. So if the policymakers do not have the clear visions that the human capital, the potential of individuals is by far the most important long-term investment any country can make for its people, future prosperity and quality of life, as said by Jin Jong Kim, President of World Bank in 2018, we will remain stuck in the same labyrinth of inequality, egocentric exclusion, and violence that we see in our country. In this pandemic, this pandemic has served as a diagnosis in many aspects for most of the world governments. were not ready. We were not ready, and Honduras were not ready with contingency plans for the situation that we experienced. On the other hand, preparedness and readiness, healthcare workers for this pandemic weren't enough. So if I see not just Honduras, Latin America, and all the initiatives we're trying to, but sometimes it just stay like trying to. And I would like to advocate more for education. As Nelson Mandela said, education is not just about knowledge and skills, it is much more than this. And education is empowerment. Education is the most powerful weapon we can use to change the world. So I strongly believe in education, education, education. And with this base, that's as not just like government, academia, and medical societies, also the World Federation of Societies and Associations. We are advocating for education everywhere, not just in Honduras, not just in Latin America, for the whole world. With this base, working with transparency and solidarity, political willingness to do what you know you must do for having unstable and healthy physical, emotional healthcare workers. Only like that you can provide a humanized and safe healthcare. Thank you.
Thank you so much, Dr. Caroline. Amanda, any exemplar that that has worked either during COVID or beyond the 5 that you gave us to add to that? Your last word, 1 minute.
Thank you. So maybe I can elaborate on one of the examples that I gave. This was a while ago. It was called the Emergency Human Resource Plan in Malawi to support salary top-ups, expand domestic training, and fill the volunteer gaps as well as TA, but also create robust M&E systems together. Donors coming together to say, here is the amount of resources that we can set aside to invest in HRH, and this is what we are looking at. And so it's also not just because donors often think it's just about salaries. Whenever we talk about HRH, it's about salaries, but there are all these layers, and salaries also need to be supported. But if we can have joint coordinated platform or initiatives to really boost the levels of a health workforce in countries, I think that for that program, it was, I think, over 50% increase in healthcare workforce, I think over a period of 4 or 5 years. And so I think that is one of the best initiatives that I have seen in terms of impact. Thank you.
Thank you so much, Amanda. We will now move on to Dr. Vanessa. What are the approaches that have been used that policymakers and leaders can learn from? I know that often we make these big asks. We make the big ask that investment must occur. And I think there is an assumption that policymakers and leaders know exactly what they should do, but perhaps they are waiting for something that is working, just as Amanda has said. Dr. Vanessa, what has worked where you are?
Thank you. I think it is important, though, to recognize that for us, I think people are daunted by the idea of investing in health workforce because it feels like it takes too long, it costs too much, and it cannot be measured. But the reality is, I don't think that is true. I think part of it is about changing and really thinking critically about how we invest. What are those timelines? So stopping, don't worry about just next year. Let's change the timeline to the next decade, because if we do this right, we should be worrying about our future for hundreds of years. We should be thinking about how we fund and what kinds of partners we fund, right? Because what this really should be doing is we look at the history of aid and aid funding, throughout time. In many ways, it's often been a Western, if you want, or US or North, South, however you like to term the term, kind of dictated agenda for what should happen. And I think at SEED, the approach that we have tried to take is to ask our partners, what are the priorities they seek to fill? What are their biggest needs in the healthcare workforce? And how can we support through the model that we do bring? So we do have a certain model that we think works well. With that model, how can we partner to look at a long-term, multi-year, 6-7 year plan to train. And so what that looks like is that we've helped support bring faculty to fill in faculty shortages, to not only provide care and to fill in some of the gaps of just the low staffing, to directly provide care, but to also partner with our colleagues on the ground to think about how do we train a rising generation of healthcare providers. But we're not writing a curriculum and dropping it on a desk. We're there for a minimum of a year at the bedside, teaching, training, clinically mentoring, providing that deep apprenticeship type experience and trying to really partner to understand how we can fill the gaps that exist in the right way to be a support and in direct collaboration. And from that, our hope is that through education, we can help transform the quality of care that can be provided for patients, because more patients are now dying from lack of quality care than they are from lack of access. And so if we think about what it means to transform quality and dignified care for a patient, we can do that at the bedside through direct clinical mentorship and through training, and then using those examples to advocate for public policy changes. And so I think just to give an example of what that can look like, for us at SEED, we help provide to a school in northern Uganda half the faculty that were required for the school to meet its accreditation. This was 7 years ago. And by sending faculty to the same school year after year after year, we've helped to graduate 3 classes of midwives, all of whom are employed, I believe, still, and who are, the vast majority are still working in Uganda, and many of whom are still working in the north, not in, say, Kampala. And Dr. Bonaventure, who will be speaking after me, can correct me if I have that wrong. But the power of that is to show the ability to be transformative through human care in these settings. I would also just share the story that health sector jobs are more resilient in recession, and that health sector positions actually can be powerful impetuses for creating economic growth in countries. So we have to stop seeing this as an either or, but a yes and. And a country like Rwanda that spent 7 years investing in training its entire healthcare workforce over the span of a decade now is seeing the most precipitous declines in HIV deaths in the world over a span of a decade, the most precipitous declines in TB death over a span of a decade on the African continent. And I think a 60 to 70% drop in mortality among maternal mortality and child mortality. That's the power of investing in a healthcare workforce comprehensively.
Brilliant. Thank you so much. And goodness, we are running out of time, so I won't make any comments on what you just said. I hope that our listeners are taking notes and are borrowing from these brilliant ideas. Now I want to invite Dr. Bonaventure Ahisibwe, the Regional Director, Strategy and Innovation, and Country Director, SEED Global Health Uganda, to give us the closing remarks. And perhaps, Dr. Bonaventure, really inspiring action is coming through these narratives. So how do we learn from the past? How do we strengthen the present? And how do we fortify the future? And how do we bring all these amazing recommendations from our panelists today together to inspire action where it needs to occur? Dr. Bonaventure.
Thank you so much, Dr. Rose Clarke Nanyonga. It's an honor to join this conversation, and more so to come off such a very articulate panel of speakers. Thank you so much. Speaking of learning from the past, strengthening the present, and fortifying the future. What a time in our lifetime to be speaking about this. Learning from the past, listening to Amanda's comments reminded me of Her Royal Highness Princess Mona Al Hussein's remarks at the opening of the 73rd World Health Assembly. And I'll quote her words. This preceded the announcement of the 2021 as the year of the health and care worker that is currently themed Protect, Invest Together, the year of the health and care worker. So in her words, she stated, applause without action is no longer acceptable. Recognition without rights and remuneration is not sufficient. A resolution without implementation is not governance. Even the best strategies and plans will not succeed without the people deliver them. I found this a very powerful call to action for investment and celebration of health workers. We celebrated health workers, we applauded them, and now what? Nature has taught us a lot of tough lessons in the last couple of years, and we owe it to ourselves and the next generation to pick up the pieces and emerge more resilient. We lost over 500 health workers in just 6 months in an Ebola outbreak in West Africa, and saw an unprecedented 23% reduction in health service delivery. Just when we thought we had seen the worst, COVID struck. And it was heartbreaking yesterday to hear Dr. Tedros announce in the opening remarks of the 74th World Health Assembly that at least 115,000 health workers have so far died of COVID. In some countries, we've seen health worker infections accounting for over 19% of all COVID cases. This is a lot for us to learn from, ponder on, and think about how to strengthen the present and fortify the future. Coming out of the devastation by the first wave of COVID-19, the silver lining is that the whole world now knows too well what it takes to leave our first line of defense, the frontline health workers, vulnerable to such an exposure. Awareness, however, is only a means to the end. Everyone knows it, but so what? We need to walk the talk. Ensure access to vaccines is equitable, that health workers are prioritized because they are at the front line and they tend to be the buffer for the shock of the epidemic. We need to train frontline health workers in infection control, equip them with the necessary personal protective equipment, address the long working hours. It's not just in resource-limited settings. Tons of physicians have to drive on a full bladder so that they don't doze on the highway. In the United States of America, these are all occupational hazards that we need to start to think through. It's not just an issue of money. We need to challenge communities through influencers and thought leaders to denounce violence against health workers. We've seen health workers being attacked in DR Congo in the Ebola outbreak. We've seen examples from Equatorial Guinea. We've seen examples in developed countries of health workers coming under attack during the COVID pandemic by attendants, relatives, and others. Very profoundly, we need to hold governments accountable to international commitments that they have ratified. We've seen tons of commitments being made by ministers of health and presidents and prime ministers at occasions of the World Health Assembly, the UN General Assembly. But when it comes to walking the talk, no one is able to hold them accountable. It's the same governments that determine what is priority, the same governments that determine what is available to fund their priorities. So empowering, being part of the conversation, engaging legislators, engaging the ministries of finance, beyond just the traditional players, the ministries of health and education, we need to ensure that when it comes to appropriation and budgeting, sufficient funding is put for the health workforce. There's no way that these investment priorities are going to live to pass if those resources are actually not operationalized in country governments and donor investments. Fortifying the future. We need to proactively cultivate a new narrative for decades to come, not just today, not just reacting to COVID. Health workforce is not an expenditure. We've learned that very painfully, and we cannot afford to lose those lessons. Health workforce investment is a cost-effective investment, an economic imperative, an integral part of social transformation that is required to future-proof the globe from disasters like COVID-19. 115,000 health worker deaths. Think about it. This amounts over $30 billion lost in potential lifetime return on investment. Investing in healthcare workers increases productivity, it increases job prospects, promotes human capital development, and ultimately drives economic growth. We have critical shortages of health workers, and we need to protect them very jealously as first line of defense for our population. And this is a collective action. It's not just health workers, not just us. It is the present, the future generations, and even the non-traditional actors. It's the celebrities. It's everyone. It's the politicians. It's everyone. It takes all hands on deck. In my final call to action, when the world leaders came together at the UN high-level meeting on universal health coverage, they agreed unanimously that to achieve universal health coverage, we should leave no one behind. This should move from a slogan to something that we truly believe and we walk the talk. We are running a tight race. We will do our part and pass on the baton. We should do it very diligently so that we can pass on to the next generation with pride. We should each be an ambassador, find spaces at the table and open doors for more advocates for a safer, fulfilled health workforce, empowered to protect the population that it is asked to. As health workers, we should not only be role models for ethics and competence so that the world has reason to see hope in us, but also a voice that educates the world on what has to be in place for health workers to perform their roles. I am very proud on that note that we're not walking this journey alone. We're involving communities and the next generation of health workers in defining priorities and shaping the narrative. It's therefore an honor to announce that on the 24th of June, a movement of health professional students promoting patient-centered care across Africa will be born. It derives its roots from the 34th General Assembly of the Scientific Conference of the Federation of African Medical Students Association. The interim leader, a fourth-year medical student at Mbarara University of Science and Technology, Jolie David Muganzi, is with us today and extends an invite to all of you for the launch of this pivotal initiative. And the details will be shared with all of you after this session. In conclusion, just like these students, if we could draw inspiration from there, we all need to show up, step up, speak up, and above all, model the image of the health and care worker that we're selling to the world. The time is now. There's no tomorrow. Tomorrow is today. Thank you.
Thank you so much, Dr. Bonaventure. Now, can we have all our panelists back on the screen? I want to belabor all the incredible points that they have made. I want to acknowledge our sponsors for this event, which has been brought to you by the ActForHealthWorkers campaign partners, SEED Global Health, Frontline Health Workers Coalition, the G4 Alliance, IntraHealth International, and Smile Train. A multitude of thanks to all our panelists who are now back on the screen, and to you all at home who have joined us today. Applause is not enough, as we have heard. So now what will you do to care for the care workers in your community? What is your piece of the pizza or the elephant? That is all for us today on Hindsight 2020. I'm Rose Nanyonga-Clarke, and I am delighted to have been your moderator for today's conversation. Thank you very much. Good morning, good afternoon, good evening.
Thank you, Dr. Rose, for the excellent moderation.
Thank you, Annette. Thank you, Amanda.
Good doctor.
Thank you, Vanessa. Thank you, Dr. Carolina. Thank you, Margaret.